Thanks.
Yeah, thank you all for attending the part 2 of the Autumn 25 session of the Melanoma Slide Club. No conflicts to declare. Now, I'll just summarize what we discussed, in autumn. So we have a normal melanocyte, which undergoes an initiating mutation. Then if it lands another, for example, BRAF or something along the MAP kinase pathway, the melanocyte becomes a tumor. And if, for example, those cells don't acquire any more mutations, such a tumor will lack the oncogenic fuel to progress further. So they, undergo growth arrest and senescence. If they undergo more mutations, you can get intermediate lesions. And one of the mutations is third promoter, where you can have an intermediate lesion then progressing to malignant melanoma. So what third promoter does is it gives tumor cells lifespan extension. So a cell with a third promoter, it does not have the capacity to multiply very quickly, but of course it can live forever. Then the next step is, one of the common mutations is loss of CDKN2A. Often, this is by deletions. You can have gene-level deletions, you can have exon-level deletions. But at the end of the day, the biallelic deletions, it leads to loss of function of CDKN2A, which is a very powerful tumor suppressor gene because it codes for, two tumor suppressor proteins. One is P16, which we can test for. The other is P14 INK4A, which is, an alternative reading frame of the CDKN2A gene. So what CDKN2A loss does is it overcomes cell cycle control, and oftentimes, in the setting of a melanocyte, you see it more in tumors that have invaded the dermis rather than, melanoma in situs. Now, once you have a tumor that's invaded the dermis, the next step is, of course, metastasis. So to undergo metastasis, tumor cells, but this is purely in the case of a melanocyte, what they do is they undergo mutations in genes such as P10 and TP53. In fact, at the present time, I would consider P10 as a big marker to distinguish an aggressive melanoma from not so aggressive melanoma. So hopefully we'll have it in the next iteration of the genomic test directory for us to test this gene. In addition, while all this is happening, histologically we see an increase in nuclear size, and that increase in nuclear size is because the tumor cells are they start acquiring more and more DNA in terms of whole chromosomal gains, segmental gains, and at the same time they can get losses as well. They're acquiring more, a higher tumor mutational burden. So intermediate lesions with the last WHO were called melanocytoma. Of course, it excludes entities such as dysplastic nevus. So although dysplastic nevus is an intermediate lesion, it's excluded from the melanocytoma classification. So as far as testing is concerned, this is just a snapshot of what we do in the Northeast and Yorkshire. So all we are doing is, of course, for confirmed melanoma, we test just for the therapy-related genes. For the ambiguous melanocytic lesions, all we are doing is we are trying to test so that, just to capture the number of mutations that a tumor has, because we know that one mutation benign, between 1 to maybe 5, intermediate more than 5, we are looking more in the melanoma territory. And as we go more than 5, it's more into the melanoma territory. So depending on, the size of the lesion and depending on what our differential is, you can do a small variant NGS panel, which is the M7.1 on the test directory. We can do a fusion panel, which is a 2.1 on the test directory, or we can do a copy number analysis. So depending on your GLH, there are different ways by which they assess copy number. Here we use epic array. And then, of course, third promoter, now we include it in our M7.1 panel, but in some GLHs, they do ddPCR for third promoter. You can also do FISH for small lesions for, things like cyclin D1, MEK, CDKN2A, and RREB1 and MIB analysis. So this slide I just put in after that discussion, what constitutes a SPITS, and by and large, the best description came from Dr. Barnhill's book. Now, amongst many criteria, what I find particularly useful is, of course, size of the lesion. The bigger the lesion it is, that is more than 1 centimeter, the more worried I become. And of course, with SPITS, we all know that most SPITS tumors, they have this initial rapid growth and then the lesion stabilizes, whereas melanomas are indolent, they just smolder along. So if a tumor is generally increasing in size over a long period of time, I'm more worried it's a melanoma rather than a SPITS. The other underlying features are what I consider a little more important in my routine practice. So overall monomorphous population of cells, low nuclear to cytoplasmic ratio, and also I like to see consistent nucleocytoplasmic ratio. So even if cells are of varying size, I like the nucleocytoplasmic ratio to be the same. Then the cytoplasm, in SPITS tumors, there's homogeneity with the cytoplasm. So you look at one cell, and then you look at the next cell, it's the same cytoplasmic tinctorial quality that you see across the lesion, or similar, I shouldn't say the same, congruent cyto. And of course, SPITS have nuclei with open, delicate chromatin patterns. Often the nuclear membranes are not thick. You should not see a lot of coarse chromatin. And of course, you can see nucleoli. Again, with nucleolar assessment, it's good to have personal thresholds. I use what the renal uropathologists use for renal cell carcinoma. A similar system for nucleolar grading. So if I see a nucleolus on 5x, it's prominent. If I have to go to 20x to see a nucleolus, it's just a visible nucleolus. I also, in many occasions, I also assess nucleolar-nuclear ratio, because sometimes you get very small nuclei with big nucleoli. So again, if the nucleolar size is greater than 25% of the nuclear area, I start worrying. And the other bit, which I know my first melanoma slide club, while I was still training, I remember Richard Carr mentioning the importance of communobodies. I mean, you can see communobodies outside the SPITS spectrum, but presence of communobodies and loads of them, is quite reassuring. So I'll just pause this for a while, and this is just an extra slide I added just to explain what I mean. Please give me 1 second. I'm just loading the slide because it's going to be a live. So this is a 32-year-old female, and this is a lesion on the right thigh, and the lesion was removed with a 7mm punch biopsy. And this, I'm of course, so it is a relatively well-demarcated lesion, and you have this uniform morphology with open chromatin, and again note the cytoplasm, the same tinctorial quality across the lesion. Yeah, I'm sure a significant majority of participants here would agree this is what we would call a benign compound SPITS tumor. And so just to show you, again, a discohesive population, there's a place for every cell, and there's space between cells. You don't see any nuclear overlapping, no coarse chromatin, not much in the way of communobodies. And this is a tumor that shows a BRAF fusion, the partner gene being COBL. So this is, a classical SPITS tumor showing BRAF fusion. So, and let me see if I have one more. Yeah, I just have one more slide to show you. One more case. Sorry.
Just a quick question, Bipin. So something which you thought was a classical Spitz-Nevis, would you still do the immunohistochemical markers or try and prove that it belongs to the Spitz group?
No.
Okay.
No, I don't. So this is the only classical Spitz I have where it was tested. So I don't have any other classical Spitz within the BRAF spectrum.
Okay.
Yeah. So this is another case, which is a 26-year-old female. It was a 7-millimeter pigmented lesion. And again, this has a bit of a maybe dysplastic nevus-like morphology, maybe a tiny bit. Again, epidermal hyperplasia. So you have small nests at the periphery, and as you go towards the middle, the nests are becoming, you have that gradual transition of the lesion from small nests to large nests. It's not like you have big nests here, small nests here. So there is some kind of a uniformity. And again, with these nests, if you go from one field to the other, you have a predictable architecture, nests on the sides and tips of retapex with retapex fusion. And then you go on hyper, you start seeing this discoesive epithelioid cell population that largely maintain nucleocytoplasmic ratio, but there is variation like you see in dysplastic nevi, some small nuclei, some large nuclei with visible nucleoli. Just to show you, but again, look at the cytoplasm, the tinctorial quality. You have this homogeneous eosinophilic cytoplasm, barely any pigment, and maybe some lamellar fibrosis. So this again, is a spark nevus-like morphology. I don't know whether you guys will agree. And this again shows a BRAF fusion, this time with a SOX5 partner gene. Yeah. So a classical Spitz nevus showing SOX, and then this is, a bit spark-like again with a BRAF fusion. So I'll just go back to my presentation. So we again know there are different classes of BRAF mutations. So so we know, from that not all genes are equal. There are some genes that have more room than other genes. And again, within mutations as well, for example, the class ones, with class 1 mutation, just monomers of the mutated BRAF is enough to, constitutionally activate the MAP kinase pathway. Then we have class 2, where you need dimers of BRAF to activate the pathway. And of course, class 2 fusions, class 2 mutations include, by and large, most BRAF fusions. And class 3 are the ones which where there's impaired kinase activity. So they require other molecules such as RAS or CRAF, which is also called RAF1. And so these mutations are RAS dependent. And often you see these mutations or variants as a passenger phenomenon with other driver mutations like NRAS, MAP2K1, and so on. So going on to case AK11, I'll just show you the slide. Yeah, so this is AK11. Apologies, I'm just trying to find the slide. Yeah, now before we start cracking at the slide, the approach is really simple. We are just collecting all the number of driver variants in a tumor. And we are also, looking at copy number changes. In Leeds, we follow the Alomari paper and also, to some extent, the Blocks paper on copy number changes. So we consider greater than 3 copy number changes, segmental copy number changes, as being significant, as being high risk. So that is what we are testing our cases against. Now, I cannot tell you whether that 3 is correct or not yet, but that's the the Alomari paper is what we are basing our diagnosis on. So the history given is that it's a 28-year-old male, left thigh, PRAME negative. It shows AGK BRAF fusion, third promoter negative, copy number failed. And so when I'm looking at a case, let's go to full screen. So the first question we ask ourselves is, is this sun-exposed skin? Is there severe solar elastosis? So it's not much really. And then you have this compound melanocytic proliferation. And then you're thinking, which family of lesions do we actually accommodate this, among the 9 families? Would this be Spitz? Would it be conventional? And you find lesions like these, which are like in the middle, they show some features of conventional, some features of Spitz tumor, where, you have a junctional component that shows atypia and, some dysplastic nevus like architecture, maybe a bit of spark like architecture, but you can see random atypia at the periphery. But as you go towards the middle, there's no junctional component, but you start seeing monomorphism, in this polypoid bit in areas. And also you start seeing pigmentation in the cytoplasm, which is not a particularly Spitz trait. It's quite unusual outside for example, the read setting to see pigment in, for example, HRAS mutated Spitz or ALK fused Spitz or ROS fused Spitz or NTRK, outside the read nevus, other NTRK fused Spitz. So it's not common to see pigment in the cytoplasm. And then you start looking at nuclei, you start looking at chromatin texture within one nucleus, and then you size up, is there significant variation in chromatin texture? Is there clonal heterogeneity in the setting? So I was quite worried with the clonal heterogeneity in this lesion. And we'll just go back to the presentation. And thanks to everybody who actually had a go at this. So there was a range of responses. And a lot of people went for low-risk Spitz tumor, given the third promoter negative, just BRAF fusion. I was particularly worried with the clonal heterogeneity and the fact that this was a tumor that sat at the fence between conventional and Spitz tumor. So I'll just show you what I initially reported this as. So I said, so this was early days, in my learning experience of these tumors. This must have been the 10th or 11th case I saw. And I said the above features are of a high-risk spitzoid melanocytoma. And you can see, so I put a sample of the reports. You can see how my practice has evolved as well. And of course, I'm hoping for a good discussion, just to see what others do. And I said, there's a rare subset and the prognosis is yet to be. And this was before any of the big papers came in 2023. So I said, with maximum follow-up period of 53 months, such tumors can spread to regional lymph nodes and then behave in an indolent manner. And occasional cases with distant metastasis have been described. And in these patients, distant metastasis occurred within and around 12 months of diagnosis. So at that time, I had seen only 2 cases of spitzoid tumors with BRAF fusions. And none have shown metastasis, although that follow-up I had at that time was 12 months and 7 months. And I said, this is my first case with AGK BRAF, since the 2 cases I previously encountered had other partner genes, and this was my final bet. So this case went on to have a sentinel node biopsy, subsequently, a year later in 2021. And the patient had sentinel lymph node micrometastasis in the subcapsular sinus and interfollicular region. And the larger one was 0.3 millimeter across. Now, this far, when I last checked the follow-up, the patient's all right. So that's where we are with this case. So I'll just go back to, do you want to discuss everything in the end, Aarti, or do you want to discuss on a case-to-case basis?
It's up to you, Bipin.
I mean, there's a lot to go through.
Yeah.
If
you want to go through it all then? Yeah.
Okay. Okay, then we'll crack on with the next case.
Can I just ask a question just on that case? I know we're not, but I'm a bit worried we're going to get all messed up with all the cases blurring together.
Yeah, sure.
Whereas
sure.
that's the danger of going all the way through it. Are you influenced by the depth of the lesion? Because, that's a thin lesion, it's more exophytic. Even if it was a high risk sort of genetic lesion, presumably the metastatic risk of that lesion is going to be quite small based on what would be an arbitrary Breslow thickness.
Yes. Yes, by and large, I get worried with thickness, but more than thickness, I worry with melanocyte density. I try and apply that paper from Leicester that won the BAD prize. I try and apply that to a large extent. Although morphologically, I don't do the exact count, but I try and assess melanocyte density from one field to the next. So yes, Salim, a bit of both actually, thickness and melanocyte density.
Thanks.
So we'll go on to case number 19, which was a 31-year-old female scalp. And I'll just go to the lesion. So I'll just remove this. Just trying to case number 19.
Can we just take a quick question from Samaya? I think she's got a good question, if that's okay.
Sure, Samaya. Hi.
Hi, can you hear me?
Yeah.
Just a basic question, Bipin, before we go ahead with the cases, because I noticed that from the options that you provided, you use the term low grade, high grade Spitz tumor, and as you're aware, the recent WHO is just using it as a Spitz melanocytoma. So what is the recommendation, or because usually we advise the clinicians that we need to stick to avoid any confusion, we need to stick with the WHO classification, but when they receive some reports with high grade, low grade, so what is your thoughts about that? Because this can create some confusion at the MDTs and among pathologists about that. Thank you.
Yes. To that, what I'd say is we've moved on from the WHO because increasingly there are more papers out there, including a good review paper in the European Journal of Cancer, that talk about, substratifying melanocytoma into low risk and high risk. I think the bigger question is what parameters do we use to substratify into low risk and high risk? Now, one of the criteria we use is the Alomari paper, where if we see greater than 3 copy number changes, we call it high risk. If we see, for example, a driver variant, let's say a BRAF fusion, and maybe 1 to 2 copy number variants, we call it low risk. Or we call lesions that in the past we thought were atypical, we would classify as atypical spitzoid tumors. And on genomic testing, we find a fusion variant. But even if we don't find copy number changes, because in the past we were calling them atypical spitzoid tumors, I still tend to call those low risk, although I do not have genomic evidence of more than 1 driver variant. So, I think this is we are still scratching the surface, but I'm just telling you about my current practice. What are you guys doing in Nottingham?
Actually, we are sticking to the WHO classification, and from the molecular or the genetic reports that we receive, I haven't received anyone using a low grade, high grade in terms of the genetic, abnormality. So that's why it is easier for us to just call a Spitz melanocytoma and manage and Spitz melanocytoma. So but I have received some of the question from clinician, is it low grade and high grade? And that's where the confusion usually arises, and if there is any different management calling it high grade or low grade.
because the Eurocan paper, for the low-risk ones, they recommend 2 to 5 clinical margin, whereas for the high-risk ones, they recommend 5 to 10 millimeter clinical margin. And also in the high-risk cases, actually, we deliberate them at the MDT. We deliberate it within our team here. And again, the discussion is on whether to follow up the patient like you would for a melanoma, or sometimes even consider sentinel node sampling. So, and that is a reason why we, try and stratify. But it's still early days, Samaya, and I think, but seeing that paper, the review in the European Journal of Cancer was quite heartening that other people are also, thinking in this direction and doing similar things.
The other thing is about the impulse, as well as, in previous meeting, EQA meeting, it was recommended to use the impulse classification, where the Spitz melanocytoma together with even Spitz nevus has been merged in just one category 2, and the management is the same. And that's why, for simplicity, we just use the term Spitz melanocytoma and avoid stratification into low risk and high risk. But and just having a unified, at least a national sort of practice or language will be very useful for pathologists as well as clinician for the management purpose.
Yeah, I mean, it's good to standardize, but at the same time, you don't want standardization to kind of stifle innovation, because that's one thing I worry about as well, that we are so standardized that we are all saying the earth is flat. Should we actually move a bit further and say, there's a bit of, but I fully see your point. And yes, standardization is important, but not at the cost of stifling progress. So, yeah. So shall I move on to the next one, Aarti?
Yeah.
Yeah. So this is the second case, sorry, this is case number 19, which was a 35-year-old female scalp lesion. And again, you look at the background. This is not severely sun damaged. And then you go back to the lesion. It's not particularly symmetrical. It's a bit polypoid. Again, monomorphic spindle cells, kind of raining down into the dermis. Not much in the way of a junctional component. Again, monomorphic spindle cells. Again, look at the cytoplasm. So you go from one cell to the next. There's a homogeneity to do with the cytoplasm, whether you call this, grayish pink cytoplasm or amphiphilic cytoplasm. But the cytoplasm is the same. And again, the monomorphism. And then you look at nuclear attributes. You can see a range of chromasia, some paler staining nuclei, some darker nuclei, some nuclei with nucleoli, some other nuclei without nucleoli. Not much in the way of a stromal response. There are some thick collagen bundles in between the tumor. So some fascicles, some sheets. So by and large, the same morphology from one field to the next. So the fusion panel picked, I'll just come back to the presentation.
Sorry, Bipin, this was case 19, was it?
19, case 19.
Okay, all right.
Yeah. So the fusion panel picked a ST13 BRAF fusion, and I think at that time it wasn't described in the literature. And there was no other variants and no third promoter. With copy number, there were losses, and a lot of losses which were more than 3. And on the basis of that, I call it a high-risk Spitz tumor. Now, this patient had a further excision that, as per Eurocan guidelines. And so this far, so this was in 2024, this far we haven't seen any recurrence, or we haven't seen, anything more, but the patient is being followed up like it's a high-risk lesion. Now, as far as segmental changes are concerned, I find segmental losses more powerful than segmental gains, because we know that, with the nucleus of a cell, the nucleus is able to, be stable with more DNA, but the nucleus becomes very unstable with less DNA. So I worry more when there are segmental losses as compared to segmental gains. Now, this whole presentation, look, all these cases that I put in are cases that I thought don't actually fit in to the papers that are out there. So they are different to what's described in the papers. And so these are slightly different cases with BRAF fusion. So moving on to case 12, case 12, and unfortunately the follow-up, since we've started reporting this only from maybe 2020, our follow-up is pretty limited. But then again, do think about, the classical, the first two cases I showed you with BRAF fusion that looked like a classical Spitz. And so this is case 3. So this was a 64-year-old female. Let me just check the details. Yeah, then she was 63, now she's 64. 10 millimeter lesion with 2-year history and a mitotic rate of 5 per millimeter square. And you notice that a lot of these lesions are largely intradermal with barely a junctional component. Yeah, it's kind of dome-shaped. It's got an even silhouette, suggesting that there's even growth across the lesion. Maybe here it's a bit uneven with a bulge here, but overall. And then you go on hyper, you start seeing cells that look similar, again, a homogeneous cytoplasm. Mitosis are readily seen in this case. Some nuclei have intranuclear inclusions. Again, not much in the way of intracytoplasmic pigment, not much in the way of nuclear overlapping. The chromatin texture overall is somewhat similar, So morphologically, not a high-risk lesion, except for the fact that you're not seeing much in the way of senescence with depth. So cells even at the bottom are similar to the cells at the top. And of course, 5 mitosis per millimeter square is quite high. So this was a spread of diagnosis. I think a group called it Spitz melanoma. So this case had third promoter variant. So although the morphology was not that worrying, it showed a ACAT9 BRAF fusion. So this was in 2022. And at that time, when I look for papers, the ones with ACAT9 BRAF fusion, the papers that came out, single case reports, they were all for, they were all diagnosed as melanoma. So I was a bit worried then. And then, of course, the SNP array was quite worrying as well. So this is what I said. As noted previously, this is a high-risk spitzoid melanoma, given the SNP array findings. And then I said it is now proposed that BRAF fused melanoma may represent a subgroup of tumors that could more frequently undergo full malignant transformation when compared to other fusion-associated spitzoid neoplasms. So by this time, I started identifying a group of BRAF fusion tumors that fitted well into the Spitz category. Then a group of BRAF fusion tumors that looked more like tumors in the conventional category. And then a group of BRAF fusion tumors that were, on the fence, between the conventional and Spitz category. And then occasional cases with distant metastasis have been described, and the same thing. And then at that time, this was my fourth case. None have shown, and then I said 20 months, 14 months, 9 months, and 2 months. So this was my journey at that time. And I said immediate management of these patients include a wide excision, and role of sentinel node in the setting is yet to be elucidated. So just after this came this paper, from Arnaud's group in 2023, and they looked at roughly 58 cases where they say that BRAF fusion melanocytic tumors represent a diverse group that sometimes lack typical Spitz features. And at that time, reading that sentence, I was quite relieved that, they need not all look like Spitz. And they said that in their series, stromal desmoplasia is a common feature seen in 93% of cases. And you can see that all the cases we've seen so far, there's very little in terms of stromal desmoplasia. So their series is almost concentrated on cases with stromal desmoplasia. And they talk about buckshot fibrosis, they talk about cords of cells arranged in a whorl pattern within desmoplasia, and they talk about a fascicular growth pattern. And they also say that histomorphology alone cannot distinguish benign from malignant BRAF fusion tumors, again highlighting that these tumors are a spectrum, so from the benign end to the malignant end. And morphologically, they felt that dermal mitosis and pagetoid spread correlated with malignancy, bearing in mind that a lot of these tumors we've seen this far barely had a junctional component. So any questions, Aarti, or we can move on to case 13?
No questions so far.
Okay.
I think Arjun's got his hand up.
Oh, sorry. Yeah, Arjun.
Arjun.
Sorry. Hi. Thanks. Thank you so much, Bipin. This is absolutely brilliant. I just wanted to ask you, so at this point, would you agree that rather than the conventional approach of saying if it's anything Spitz, then there's no chance of neoplastic atopia or progression to malignancy, that you are moving away from that, and that the morphologically Spitz or Spitzoid features is just a class of melanocytic activated melanocytic proliferation, and that after that you're finding a spectrum where some of them can be low risk and some of them can be high risk, and you still have to assess the lesion independent of its Spitz morphology. Is that what you're coming to? Is that a fair comment?
Yeah, that is a very, very fair comment, Arjun. Very, very fair comment.
Thank you.
Thank you. So this is case 13, and so case 13, 34-year-old female, right upper back lesion. So BRAF fusion was detected, no evidence of any other variants, and PRAME was negative. So I'll just share my screen. Again, you have a compound melanocytic proliferation, not in severely sun-damaged skin. Again, you have a predictable architecture, nests on the sides and tips of retapex, although you can't see, that typical gradient where you have small nests at the periphery and larger nests towards the central. So you have varying size nests, but within the nests, again, you have relatively monomorphic epithelioid melanocytes, but again, many contain pigment. And this is something you don't see in most Spitz tumors, except ones in the Reed family. Finding cytoplasmic pigment is, again, a feature you can see in BRAF fusion tumors. And in some BRAF fusion tumors, you can see that classical, morphology described for BRAF V600E mutated tumors, that frothy pale cytoplasm and dirty pigment as well. But here, again, the tinctorial quality, the cytoplasm is similar across the lesion, no pagetoid spread. And this is the, dermal component. no heterogeneity, chromatin texture, similar throughout the lesion. Again, there's a reduction in nest size with depth, no marginal mitosis. But again, we don't see the senescence that we see in conventional tumors. So where I was going with this is, oftentimes people worry about SPITs when they compare a SPITs with a conventional nevus. But what I recommend is that, when you're assigning a tumor into a particular family, so if you're assigning this tumor into a SPITs family, you have to look at the atypia or the range of atypia you see in the SPITs family. So that's your threshold. And then you assess this lesion based on that threshold. Because the moment you are assessing lesions like these, with your threshold for conventional family, you can, worry about these lesions. So this was the spread of diagnosis. The majority, of course, went for benign Spitz tumor or lower Spitz tumor, and I'd agree with either. So I call it a lower Spitz melanocytoma because, again, this was early on in my, journey in diagnosis of these lesions. And at that time, most papers, on BRAF fusions were papers that people, randomly call melanoma. In fact, in most of those papers, although they call lesions melanoma, many of them didn't have long-term follow-up. So I said, until recently, due to selection bias, the literature was skewed towards the malignant end of the spectrum. So the morphological features of this tumor is more on the benign end of the spectrum. So that was my comment. So case number 14, I'll just load up the slide if there are any questions, Aarti.
I did have a question. You were talking about thresholds and how they change depending on when you've assigned the family. I was thinking about Spitz in children, which can have polyploidy and quite large cells. And does that influence you? How do you interpret polyploidy and large cells in the context of Spitz?
The thing is, what you said initially, that under 10 years old, some lesions that I've seen behave in a benign fashion have had atypical mitosis, sheets of cells that early on my career, I've worried, and some I had called Spitz melanoma. But, in fact, I have more than 10 years of follow-up on some of those cases, and nothing's happened. So now if somebody is under 10 years old, in fact, in the recent years, I've seen a few even that are PRAME positive, more than 70%. And, I've more favored a low-risk lesions, and those lesions are behaving in a low-risk manner, Salim. By and large, I try, applying similar methodology. I sequence. I look for, how many genomic aberrations are there. But look, I'm repeating myself with, even very ugly-looking lesions in Spitz lesions in patients under 10. My threshold is very, very high. As in, I can those lesions can get away with murder, and still I'd be, leaning towards the low-risk end of the spectrum.
Yeah. I think Samaya's got
What do you do?
Yeah, well, I really have a much higher threshold as well. I've seen some really wild-looking Spitz, sometimes actually in just 2 or 3-year-olds, and you almost just accept that's what they look like. But I haven't necessarily got the genetic data on those cases. Obviously now I would pursue the genetics on most of these cases, but they look wild. But I think it's just a feature we can allow.
Samaya?
Thanks, Bipin. Just a quick question from the practical point of view. I assume the BRAF fusion actually cannot be detected by the IHC with the V600E. So it may be for a case like that, where is it conventional or is it spitzoid? Maybe a BRAF can be used as a triage. Is that right? Or fusion can be picked by this antibody? That's what I'm asking.
Yeah, fusion cannot be picked by the BRAF V600E antibody, because the BRAF V600E antibody does not even detect other variants like, E2, KR. So it's so specific for V600E, Samaya. In the early days, Will and I did try the BRAF fusion probe for fish. But what happens is that, so BRAF resides on chromosome 7. And most of its partner genes also reside on chromosome 7. So when you have, rearrangements in the same chromosome, fish does not work very well at all. So even with fish, it can be challenging. Now, with this discussion, maybe rather than getting it a bit more complicated, I must warn you. Now, you may see a case, for example, that looks like a BRAF fusion tumor, exactly as what's described in, Arno's paper. But you send it for NGS, and most NGS is RNA sequencing. And in RNA sequencing, you are looking for a chimeric gene. So you have the BRAF gene that's married to another gene, and the kinase portion of the BRAF gene is active. So, but sometimes, so RNA sequencing can pick this chimeric gene, but the problem is that sometimes the fusion is just with the promoter of another gene. So you really don't have a chimeric gene. So all you have is the normal BRAF gene, but fused to a promoter of that gene, which our current technologies don't pick. Now, when we move on to a technology like nanopore and so on, it is likely. So this is, I've noticed a pitfall, and I've seen it in ALK fusion cases where the morphology looks like ALK fusion, but you send it for fusion analysis. There is no fusion, but you do the ALK D5F3 clone, you see wall-to-wall staining. So the absence of a fusion in those scenarios should not prevent you from calling it an ALK fusion SPITS, provided the morphology is of a SPITS. Of course, melanoma can show ALK fusion as well. But I said if the morphology is like a SPITS and you have positive immuno, but the fusion panel is negative, it could still be, promoter due to promoter swapping. That there is a ALK fusion, but it's not detectable by current techniques. So there are many such pitfalls, even with genomic testing. So I think it is using immunos, using fish whenever, depending on the context, and then using sequencing. I think putting all the three, it helps maybe in 50 to 60% of the cases, but around 40% of the cases, a third of the cases, you just can't be sure. So case 14 is a 13-year-old male, 14 millimeter nodule. Now this is a super interesting case, and to be honest, I'm still not sure about this case, but it's a young patient, and it's a compound melanocytic proliferation. And I mean, I suspect the majority would put this in the SPITS spectrum, some lymphoid aggregates. But what really worried us about this case is the variation in chromatin texture, the variation in nuclear features across the lesion. And what also worried us was the melanocyte density across the lesion. And again, the absence of maturation and so on. Let's have a look at the PRAME. Yeah, no PRAME staining. Yeah. And there was a mixture of, again, a range of differentials, and a group of people called it conventional melanoma, because currently the WHO, says that a SPITS cannot have BRAF V600 mutation. Yeah. And the EPIC array, interestingly, showed segmental amplification of 7q. So 7q, so BRAF resides on the long arm of chromosome 7. So not only is there BRAF V600E mutation, there are multiple copies of this, okay, in the genome. So it's just a steroid, BRAF on, mutation on steroids, really. But otherwise, the genome is silent. And this was, our report as well. It has a spitzoid morphology, how it displays marked architecture and cytology. It has demonstrated a BRAF mutation and appeared to show BRAF amplification, unusual combinations. And then, at that time, there was this publication on BAMS. And then, based on the degree of architecture and cytological atypia, it was labeled as a spitzoid melanoma, and based on the WHO. And anyway, the patient had a wider excision, no sentinel node, no recurrence to date. And given all this, and given the thickness of the tumor, and let me just go back, let me see if I measure the thickness. So it was a 14 millimeter nodule, and the tumor was, let me see if I can find the thickness. Sorry, I can't find the thickness, but let's measure it, actually. We can measure it here. Yeah, in excess 4.75 millimeter. So quite a thick lesion. So, but it was quite eye-opening, this case. And I'll come to the reasons why. Let's move on to the next slide. So consider a Spitz-Nevi with HRAS mutation. Now, Dr. Bastian's described Spitz-Nevi with HRAS mutation, also showing 11p copy number. So 11p is where HRAS's home is. And those lesions, with HRAS mutation and then multiple copies of that mutated HRAS, they are again a Spitz on steroids. So what he describes as larger, predominantly intradermal desmoplasia, characteristic cytological features which are large. So if there's time, I can show you guys a few cases of this. So you see massive but Spitz cells, and they have an infiltrating growth pattern. And also I've seen cases of HRAS mutation with 11p copy number in the desmoplastic Spitz setting, where you see again large Spitz cells, large cells with abundant eosinophilic cytoplasm, big vesicular nuclei in a desmoplastic stroma. Then the second paper, again, is, Dr. Linos's case where they, and of course, the other, Steve Billings has also, published a paper on this, where they talk about sclerosing melanocytic tumors with MAP2K1 inframed deletions and 15q gains. Again, these are tumors that have a Spitz or spitzoid morphology. They have MAP2K1 deletions, inframed deletions, and they also have 15q gains, and that is where MAP2K1 resides. So you have mutated MAP2K1, and amplification of this mutation, and again, tumors with a Spitz morphology. And the third paper was a series, again, from Dr. Bastian's group, more recent, again, where they describe NRAS mutated cases, where in the same paper, they highlight that these tumors look very Spitz-like, but they show, amplification of chromosome 1, where NRAS resides. So my current thought is, when you have a mutation, let's say in one of the MAP kinase genes, and you have amplification of, multiple copies of that gene, either that gene only, or you have amplification of that segment of the chromosome, you can still get a Spitz morphology. And perhaps, so what these papers describe are tumors that have Spitz morphology, not entirely typical, but by and large behave in a benign fashion. So I am having second thoughts on that diagnosis, but I was just wondering whether any of you had similar experiences. Any questions, Aarti?
No particular questions popping up. There are lots of comments. Could I ask, Bipin, on that case, what did you think about the junctional? I know the cells were in the dermis looked very spitzoid, but would you categorize the junctional proliferation as it was very lentiginous and with lots of
Yeah.
thinning of the epidermis and things which we would normally not associate with the spits, for example?
That's correct. That's correct. But some NTRK fusion spits can have a good lentiginous component. Now I've seen ALK once, superficial, what Cynthia McGraw, described as superficial atypical spitzoid tumor, those with lentiginous components. So yes, lentiginous proliferation in a spits is uncommon, but I think it can be seen. And of course you use molecular, but I agree, Arti. We were quite worried by all of them, which is why our diagnosis was spitzoid melanoma. But this is 4.75 millimeter thick, and so far we haven't had any progression. Maybe in 10 years time.
Yeah.
But yeah.
So we've got Sue and Salim.
Sue?
Hi, Bipin. Sorry, I think we were wondering about the third P negativity. I don't know if you touched on that. Do you tend to get them negative in melanomas?
What negative? Sorry?
I think your third promoter analysis was negative.
Yes, in this case, yes.
Yeah, so does that happen in melanomas in your experience?
So third promoter, the biggest series, they say, so the biggest series of conventional melanocytic tumors, they say that third promoter is an early event in more than 70% of the cases. So a lot of third promoter studies are on conventional category, very little in terms of third promoter in the other families. So like DPN or BAP1 or SPITS. Now, with molecular testing, the presence of third promoter supports a diagnosis of melanoma. The absence of third promoter does not exclude a melanoma. So it's got positive predictive value. But I think as pathologists, sometimes we think if something's not there, then it favors this. But I wouldn't say that. Salim?
I was just going to make a comment or a question about these BAMS lesions. I think for me at the moment, unless it's an absolutely classical spits morphology, everything fits. In other words, I'm going more towards the benign end. I'm not really happy with the term, applying the term BAMS to anything with the BRAF V600E mutation. So for me, if there's any slightly odd features, I just steer clear of that. I don't know if that's right or wrong, but that's just where I'm at with BAMS.
It's the same, we have the same practice, but I'll quickly mention an anecdote if Will does not mind. This was one of a case, this was a few years back, where Will was looking at a case and he was very excited. So, and it was late one evening, and then we saw the case together and we thought, man, this is the best BAM that we've ever seen. It looked absolutely Spitz-like. Now, he thought, okay, we need to, and when the report came to us, it also said sequencing was done, that it showed a BRAF V600E mutation. But for one reason or the other, we thought we'll do a broader panel. And when we did our panel, it didn't show a BRAF V600E mutation. It actually showed an NTRK fusion. And it turned out that the original testing was not right. Mm-hmm. So, so just sharing an anecdote. So we always look at, as you said, it has to look like a typical Spitz, and we need to be really, really sure it has nothing else. In addition to, and it definitely has BRAF V600E.
A few other people. Eleni?
I don't know if Somaya's first. I'll just be very quick. About the third promoter mutation, it was a little bit scary when that presentation by Armita Bahrami a few years back in her papers in children, showed that the spits that looked even less worrisome were the ones that had the third promoter mutation that actually were lethal melanomas. And she also went on about a case that was third promoter mutation negative, but was lethal. And they identified that other third promoter aberrations that play a role is actually mutation of the third gene or methylation. So third promoter mutation negativity does not mean that you don't have the other two or maybe others that we don't know yet. That is why it is very important to have this pre-test probability based on all our criteria, and we saw in the cases earlier. And another comment about the BAMs. From the few papers that I have reviewed, I tended to reach the conclusion that I would call it a BAMS if the atypia wasn't severe. So like a cutoff up to moderate, to call it SPIDS BAMS. And if it's more, I might be tempted to move away from that completely and worry about BRAF with spitzoid and worse prognosis. But of course, it's very arbitrary where everybody puts the moderate to severe cutoff. So just a comment from me.
I mean, fully agree, and you're absolutely right. For tumors they want to become immortal, so they can use the TERT pathway, or there are other pathways outside TERT as well that they can use. But you're right, in the TERT pathway, commonly they exploit the TERT promoter. But you're right, you can get rearrangement of the TERT gene, or you can have mutations in the TERT gene. So all of that can help with tumor cells becoming immortal. Yeah. Arti, you said there was one other.
Maya, go ahead.
Yes, thanks, Arti. I just because I can see the genetics is actually not very helpful in this case, putting the case in one category or the other. I just want to refer to a paper done by Kalonji and Pernell a long time ago in this category of sort of spitz tumor in adolescents and the children. If it would be help in this sort of scenario where they are using ulceration, lesion size, subcutaneous extension, number of mitosis in order to categorize the lesion into low-grade, intermediate, and high-grade. And according to their criteria, this is actually a sort of intermediate to low-grade. I don't know the size; it's not mentioned in the clinical details, but this is between low to intermediate grade. So, would you consider this sort of classification? Is it still valid? It is obviously before the genetic era and stuff. But do you use this sort of categorization in this age group at all, Bipin?
I do, because I was trained, with that criteria. So that's kind of embedded in my DNA. So when I look at a SPITZ, I still have those criteria, and Ray Barnhill's criteria, and at this point, I am at a juncture where there are those criteria, and then now I'm slowly beginning my journey with the molecular testing. So I'm using molecular testing to refine those criteria in my practice. So you would find that when you start doing that, some of the criteria in those papers that people were worried about are no more valid, and some of the criteria are still valid. So at the moment, I'm just slowly trying to refine those criteria. Yeah.
SPATS grading is I think what we're referring to.
SPATS grading. Alan SPATS grading. Yeah. I mean, Arti would tell you that we've been trying to apply SPATS grading on some ALK tumors, and you apply SPATS grading. Many of these ALK fusion tumors can be very, very worrying, but all of them behave in a benign fashion. 99.999% of them. So moving on to case number 15. Is a 53-year-old female, right thigh excision, 22 millimeter lesion. So so here's the lesion and the right upper lobe hilar lymph node biopsy. So we have some follow-up as well on this patient. So again, not much in the way of a junctional component. It's largely, dermal and expansile dermal. But again, this is a tumor where you struggle, is it conventional? Is it Spitz? Because conventional is all the tumors you see. Spitz is the tumor I showed initially, the first 2 slides. Where does this fit in? And of course, this is not particularly sun-damaged skin. Yeah. But again, look at the cytoplasm here. Look at the cytoplasm here. Look at the cytoplasm here. So as you go across this tumor, you start seeing clonal heterogeneity in terms of variation of cytoplasm and nuclear features. And you start seeing variation in nuclear density. Even at this bar, you can see variation in nuclear density across the lesion. You know that these areas are quite cellular and these areas are less cellular. And it's quite a thick tumor. And I think there was, significant mitotic activity as well. So this was the primary, and of course the hilar node biopsy, which you saw, showed the metastasis. So, and so the main diagnosis, so conventional melanoma, a large majority of people, Spitz melanoma, 46.2% of people. Now, when I thought this would be a conventional melanoma, but with BRAF fusion, because based on my thresholds for a Spitz, it didn't fit in. The degree of heterogeneity, and the nuclear features were not typical of a Spitz. And this is based on Ray Barnhill's criteria for a Spitz. So this was way an outlier for those criteria. But I can see why people called it a Spitz melanoma. And probably, this lesion is again, in that fence between conventional and Spitz melanoma. And third promoter analysis was negative. And again, you can see that this tumor, the genome, from whatever we can test, with the panels we are using, it just showed segmental amplification of 7q. And 7q, we know, is where BRAF V600 BRAF resides. And so we not only have a BRAF V600E mutation, but we also have multiple copies of that mutation. So multiple BRAF genes with that mutation. So again, BRAF on steroids. But unlike that case, that was a child, 13-year-old. This is a 53-year-old female. So this patient had metastatic melanoma on the hilar node biopsy. They had brain mets, and for which they had gamma knife surgery. They were on immunotherapy. They developed, toxicity due to immunotherapy. Interestingly, they are responding to immunotherapy. Then there was a new necrotic node in the paratracheal region, 23 times 15 millimeter. And notice that this tumor has not gone to regional nodes. It's gone straight to the lung, and the brain. And also, and finally in 2025, the CT showed reduction in size of paratracheal node. And in Jan 2026, post-immunotherapy, no evidence of metastatic disease. MRI was stable. So that's where we are with this patient. So that brings us to the next paper of our journey from Pedram Jarami in December 2024, where they went beyond Arno's paper. And what they showed was other morphologic patterns, dysplastic nevus-like morphology, which was the second case I showed you, and then a deep penetrating nevus morphology, a plexiform arrangement. Do bear in mind that I've also seen deep penetrating nevi with BRAF fusion and beta-catenin mutation. I mean, so that can also happen, but some purely BRAF fusion tumors with deep penetrating phenotype have also been described. And what they said that in their case series, I think slightly more than 30 cases, maybe 38 cases or 34 cases, what they said was when they did a PCA plot, non-supervised PCA plot, no matter what these lesions look like, whether it's spistoid or conventional or things in the middle, they all clustered in the same genomic area, genomic category. So that brings us to the next case. Any questions, Aarti?
I have a question, and I think somebody's commenting on the same. So the case 15, with the BRAF fusion, you would still be thinking conventional melanoma rather than Spitz melanoma.
I mean, because on morphology, it was, in my opinion, my threshold way outside the Spitz spectrum.
Okay, based on
Because,
morphology.
Yeah.
Not molecular definition on this case.
Not so that is the dilemma, Eleni.
Yeah.
So what I'm trying to highlight through this is the dilemma. Do we stick to the morphology that this is Spitz, and then this is a Spitz driven by this fusion? Then this is a tumor that's kind of a hybrid, and this is a tumor that's conventional. So
So the same is reflected in the papers that you mentioned with the NRAS mutation and amplification.
Right.
If it's NRAS mutant, do we consider it conventional? While at the same time we have accepted HRAS mutant Spitz nevi,
That's
right?
correct.
So it's a matter of definition. Yes, still open. Yeah. Thank you.
It's still open. And just to illustrate that the current WHO classes, is a good step in the right direction towards molecular classification. But I think eventually I can see melanocytic tumors going in the direction of CNS tumors in the way they are classified into a more molecular classification. So I think probably that would be a good direction.
Just a comment there, Bipin. I think in the last ISDP meeting in Cape Town, there was a paper presented, I think, on conventional melanomas, but showing BRAF fusion. So it's sort of similar to what you were saying, like ALK fusions you might get in conventional melanomas as well. So, yeah. And in that case that you just presented, 53-year-old full of mitoses, very atypical looking, most people probably wouldn't do any molecular, isn't there? We would just call it a conventional melanoma straight away.
Absolutely. Absolutely.
We are running a little bit behind time, but it's fine.
Oh, I apologize.
No, you did start a bit late, so we can have another 10-15 minutes. Yeah.
Thank you. Thanks, Aarti. So moving on quickly. So this is case number 20, which was a 24-year-old male left buttock lesion. Again, fusion panel, GTF21 BRAF fusion. Again, most of these cases, have fusions that are not in the literature. So I tried and picked cases that are not currently, they weren't described at that time. And again, you can see all these segmental anomalies, and you straight away can see that, this is a high-risk lesion, because you are seeing more than 3 segmental anomalies. And based on the Alomari paper and, papers on copy number, this would be a high-risk lesion. And this is a lesion, that's kind of polypoid. And one of the reasons I'm showing this lesion is that oftentimes, the teaching is that when you have a fusion, cells are monomorphic. When you see clonal heterogeneity, it's possibly tumors driven by small variants and multiple small variants. But BRAF fusion tumors are quite interesting, where you can see, a range of morphologies. So where in areas tumor looks Spitz-like, in areas tumor look a bit nevic, and see again nevus-like areas, Spitz-like areas, and this kind of stromal response, which has been described, in these Spitz tumors. So this was just to highlight, and this tumor is massive, and in old money, going into the subcutaneous, this would be a atypical Spitz tumor, in which case, I'm looking at the Spitz melanocytoma category already. And given the copy number changes, I'd call this high risk. And particularly when you have marginal mitoses and so on, you're bordering on Spitz melanoma, high-risk Spitz melanocytoma category. And again, note the cytoplasm where the tumor looks Spitz-like is the same morphology, well-defined cell membranes, this kind of glassy, pale eosinophilic cytoplasm, and that homogeneity with, in the cytoplasmic attributes that you generally don't see in conventional melanocytic neoplasms. So just to show you what I mean by homogeneity of the cytoplasm. And again, there is some homogeneity with the nuclear texture. And also to show you that, 2 or 3 populations of cells, some looking spitzoid, some looking a bit nevoid, some looking in between. So, and this is a range of diagnosis. And of course, some people favored, the majority favored high-risk Spitz tumor. And this is this was more a recent case where I now stopped using the term Spitz anymore because, this is not your classical Spitz. This is not your classical conventional. And it's a tumor, that's riding the fence here. So I just called it a high-risk melanocytoma. And the mitotic count was 2 per millimeter square. So the patients had a wider excision, no sentinel node. I'm not aware that, there's been a recurrence so far, but, we've had follow-up for 2 years.
So I have a quick question, Bipin. So in this case, there were a lot of losses, weren't there?
Yes.
So what would be your threshold then to push something which looks atypical into a melanoma category?
To me, this was on the fence, Aarti.
Okay.
This was on the fence. The big challenge is I didn't see, the degree of nucleotypia that I would, for my thresholds for a conventional melanoma.
Okay.
But again, that is variable from one individual to the other. And again, the Somaya's point, that we need to standardize. I know we need to standardize, but even within Spitz, even amongst experts, what somebody calls a Spitz, is still so variable because even defining a Spitz, there's no standardized criteria. Then moving on to the next level. So you have built a foundation, that is very fragile. And on top of that, you have a category of atypical spitzoid tumor. And you have built criteria on top of this fragile criteria. So it's basically a house of cards, really. And
I like that comparison. That is very true. We have some hands, Bipin. So Somaya and then Arjun. I know we're running behind time, but we'll take.
Sorry, guys. I just, this one. How about the stump, Bipin? So at least in my eye, to be honest, and I'm a bit worried about this lesion. So how about stump? When do you use a stump, and does it matter what is the management difference if you're using high-grade Spitz melanocytoma, as you call it, or stump? What is the management difference is going to be? Thank you.
So with high-risk Spitz melanocytoma, for example, yesterday's MDT, one of my colleagues, Dr. Palmer, and we reported a case as a high-risk melanocytoma, and the MDT might consider a sentinel node. And of course, the follow-up will be like a melanoma, as per our local guidelines. Does that help, Somaya?
Yes, that is the risk of using this stump, but to be honest, the pattern and cytology, I agree with you that the morphology looks fusion-like, but there is some atypical features in this one, which I would be a little bit hesitant calling it just a Spitz melanocytoma, even on the high end. But maybe a discussion at the MDT. I'm not sure if sentinel lymph node is already ruled as a standard for Spitz tumor in the UK.
No, they don't. In fact, by and large, we've never done, even for atypical spitzoid tumors, we've never done sentinel node in our team. But these are cases where, these are not your regular BRAF fusion cases. They are ones that, that kind of tread that ground between conventional and Spitz tumors. So I'm just trying to highlight that there are categories in between them too. Yeah. Arti, there was somebody else, sorry.
Sorry, you can move on, I think, Bipin.
Yeah.
That's it. Yeah.
So case 17. Sorry, I'm just, I should have done this before. Case 17. Sorry. Yeah, so this was a lesion on swelling on the left wrist. And the patient's only 12 years old. And they say that it was present since birth. So that's
sorry, Bipin, I think that's AK 18, AL 18, I think. But yeah, go ahead. The history matches, but on the system, it's 18.
Sorry, apologies. Maybe I got it wrong in the slide. Yeah, I might just quickly change.
I mean, you can do that just for the audience to know that we're discussing AL 18.
That's correct. That's correct, Arti. Yeah. I think, when I did that last minute redressal of the slides.
Okay, yeah, no, go ahead.
And this may feed into, Dr. Linos's lecture later today, So again, you have a mainly intradermal lesion. And again, you're seeing, these more nevoid cells, and then you're seeing cells with this homogeneous cytoplasm, some nuclear variation, but again, cells that you would assign to the Spitz category. And again, some stromal desmoplasia. And again, a lesion that's kind of living in harmony despite the 12 years. So the patients had it all their life. Yeah. It's not entering the perifollicular sheath. So it's living in harmony with native adnexal structures. Here, of course, it's more expansile. You can't see any adnexal structures in between. Again, similar morphology across the lesion. Yeah. And again, non-Sundamate skin, again, more nevoid aggregates. So yeah, I'll change this later. Oh, sorry, that should be the next case, Arti. Wait. Yeah, this is the case.
This is the one we are discussing, yeah.
Yeah, this is the one we are discussing. So now BRAF AGK fusion was detected. No driver variants detected. No third promoter variant. Copy number, segmental 7q gain. Yeah. So the previous cases, the first case I showed you was a BRAF V600 small variant with segmental 7q gain, showing a Spitz morphology. Then we saw that melanoma in that older lady with lung metastasis, where there was a BRAF fusion with 7q gain. That 7q amplification means multiple copies of 7q, meaning multiple copies of that chimeric gene. And this again showed 7q gain. Yeah. So here I have one example with 7q gain that was called conventional melanoma. But the morphology of this is so different from that tumor which metastasized to the lung, which was, I think, case 15. So eventually, I said BRAF AGK fusion associated with segmental gain of 7q. And because there is amplification, so amplification of 7q I call it a high-risk melanocytoma. And I did not recommend a sentinel node biopsy. Yeah. Now, some of you may call it low risk, and it's also been there for 12 years. Yeah. So deep within, I think it probably is low risk. But based on my previous experience, because on one hand, I've seen 7q gain when nothing's happened. On the other hand, I've seen 7q gain as the only genomic event where we've seen metastasis. And then there's this case with 7q gain again, which I wasn't confident calling it low risk. And therefore I called it high risk. So this is more, defensive practice, you can call it. Or, the lack of certainty on my part to actually be confident that this is low risk. So in morphology, I was not that worried, but it was a 7q gain, and there's only one copy number alteration. So it's less than 3 even in terms of copy number alteration. But there was something to this that worried me, I think, which was, I think, the P16. Was it the P16? So there were areas of the lesion like this with P16 loss and other areas with checkerboard pattern. Yeah. Now, copy number did not show CDKN2A deletion, but you must remember that for copy number analysis, we are providing DNA of all these cells. So even if there's a subclone here that shows CDKN2A loss, copy number will not pick.
Bipin, excuse me, may I interrupt?
Sure, you can.
I think there's confusion on the EQA website. I think the clinical images you're sharing and discussing for clinical information for a different case. So I'm quite confused.
So this is case number, what I have here is case number 17.
So
maybe
if I read out case 17, that says a 63-year-old female, left posterior lower back, and pre-active RNA fusion pan BRAF AGK fusion. If I open the link to the image, it's a different image.
So I think the images may be, I think there might have been some change. I have to investigate this. Ahmed, sorry, I have to investigate this.
Could you show again the histology of the case you're discussing? And then we can match it. Yeah, so
this is the histology.
Thank you.
And this is, as you can see, the 12-year-old male.
Okay. So I think 17 and 18 have been mixed up, the history with the picture. So we're discussing this histology, which is case AK17, but with the clinical of case A18.
Okay.
Looks like it. Okay.
But Bipin, what you're presenting matches, isn't it? So I think just the slide on the system.
Yeah.
Yeah, okay.
You can see 12-year-old male.
Yeah, okay.
And I can see the report as well, Arti.
Yeah, I think it's got swapped on the EQA website.
Yeah. Yeah, so this is, just to confirm, this is swelling left wrist, and clinically they thought query neurofibroma. Yeah. So let's go back to case 17, which again, I'll confirm.
Sorry, Bipin, may I just make a comment there? Just because I know you're pressed for time, but I'll just say this because it's very interesting with the P16, what you're showing, and the discussion about copy numbers. So this makes me think that although copy numbers are important, there might be other associated pathways which amplify the penetrance of the mutation. And,
of course.
And the other thing was that this is what's worried me about molecular and genetics for a long time. When you do things like P16, cyclin D1, you find various different clones expressing different profiles. But when you get a report for genetic or molecular, it sounds like you rely, or at least the test relies on a single clear sort of profile. Now, so then
Yes.
there's a clash between morphologically, you think there might be a higher risk clone within this lesion, but if it is overshadowed by the molecular signature of the background lesion, then it won't be detectable.
No, it won't be
And
detectable.
so I think that's the glaring flaw or weakness of the current molecular and genetic testing, is that it's trying to portray the whole lesion as a uniform clone with a single, and that
Right.
is not coming out in field practice. In field practice, we find, particularly with difficult lesions, particularly with show heterogeneity, clonal heterogeneity, discordance between one area and the other, very often with immunoprofiles, which also highlight the heterogeneity of the different clones. That might be, it might be oversimplified by a single positive or negative, reliance on a single positive or negative genetic or molecular test. And I just worry if that's complicating, further complicating the issue. And it's the same thing, what you were talking about.
Arjun, I think we're really behind time. Actually,
Okay.
we have to
Yeah,
probably
yeah.
finish now, Bipin. I'm really sorry because we've
Okay.
got the
Yeah,
next
yeah.
Yeah.
Sure.
speaker, the international speaker as well. Do you want to wind
Yeah.
up maybe just with one last case, perhaps, Bipin?
I mean, I've just as wait, yeah, yeah. So we spoke briefly about this idea of entropy. So what entropy does is it measures randomness or uncertainty, and we had 5 categories, conventional melanoma, benign Spitz, low risk, high risk Spitz melanoma. So when votes are split evenly across all the categories, entropy is high. What that means is there's no consensus. So if it's like 20%, 20%, 20%, 20%. So the true diagnosis is actually anyone's guess. Now, when the votes cluster around a single category, entropy is lower. And that is informative. So, and that is what we use in the EQA, where if more than 70% of the people think that something is a particular entity, we kind of, think that that is probably the right diagnosis. So as far as this data is concerned, so what these graphs are showing is how reliable we all are in diagnosing these tumors. Yeah. So what we are doing is an inverse of entropy, where if we touch 50% and above, we are able to make a reliable diagnosis, but less than 50%, we are not able to make a reliable diagnosis. And I just wanted to highlight that these lesions, even with molecular testing and the molecular data, can still be ambiguous. And you can see that, our highest score is actually, this is a December one. The responses from December, where we had a 37.6%. And this was a case which looked more like a conventional melanoma with lung met. And still, there was a range of diagnosis. And actually, that's reduced this time. So just to highlight the challenges with melanocytic tumor diagnosis.
We might as well flip a coin. This is, I mean, these were difficult cases, absolutely. But
these were difficult cases. And I just had a bonus case, but we can skip that.
Okay. Yeah. I think people would really value would be maybe like a summary of or the final diagnoses for all of the cases, because I think a couple of last cases we were not able to discuss, and there was a bit of a swap between one or two, which we can circulate after the meeting.
Yeah, I mean, I planned it to be on time, but after the EQA, I thought.
Equally, you started late as well, so that's partly it. But it was fantastic. It was really good. Thank you so much for your efforts. So, are there any questions? Last questions, I suppose. Some points to ponder. That's helpful. Some last questions from anyone, and otherwise we can. Yeah, I'm sure Bipin would be happy to take questions. So if you put your questions in the chat, Bipin, if you could answer it through the lunch break, that would be helpful. So I think we'll